just wanted to kind of welcome you today, first day. It's going to be a 30-day rotation. You're staying for 1 month or so? Okay. So what I thought of doing is giving a series of talks on the introduction to neurology, neuroscience. This is a neuroscience rotation. And today, I'm going to kind of give you an overview. I made some notes for myself. This is purely my evaluation, my assessment of patients. This is over a number of years accumulated information, information from other neurologists, from other doctors, essentially all over the world. I had the privilege of studying in different countries, different continents, if you will. And this is really based on accumulated information, accumulated knowledge, and practice over many years. Neurology is the most interesting of medicine, because unlike other areas in medicine, in neurology, the history is critical. And usually, when I finish the history, as you will see, I'm 85%, 90% sure of what the differential diagnosis is. Number two, I don't think neurology will ever be replaced by technology. That's probably the most important information today. All the other fields, they're essentially being replaced by technological advances. In the 1973-74, there was a big attempt at replacement of neurology, CAT scanning, CT scanning. And actually, I was in medical school at the time, and when I saw my first CAT scan, it was a patient with Parkinson's disease. I was sitting in the auditorium, the MNI, Montreal Neurological Institute, and it was just unbelievable. It actually suddenly forced me to become a neurologist. I was just so amazed. I had spent a year in neuroanatomy, neurophysiology, studying the brain, cutting the brain. And here I saw a picture of a CAT scan that was clearer, in a sense, than the actual neuroanatomic part of the brain that we had cut. It was just, I almost fell out of the seat. First CAT scan. Then in 1983, so almost 10 years later, the first MRI scan over here in Washington. I was just amazed. So you're very lucky in neurology, because even with the diagnostic testing, the history and the physical exam, the neurologic exam, is clearly the most important part. Neurology, unlike the other fields in medicine, whether cardiology or nephrology or whatever else you're thinking of, I predict will not be replaceable by purely technology. And not only that, but you spend a lot of time on the technology, a lot of cost in the technology, most of which you can obtain by the history and physical exam. So I wanted to kind of start off by saying you're in the best field in neurology and in the neurosciences. And what I would like to do is kind of look at some of the notes here. And let's see here. Yeah. The neurology and the neurologic information, everything I'm going to say today and in the next 5 sessions is obtainable in a book. I wrote a book on neuroscience and neurology. I think it's a 2nd chapter, and Dr. Naka will be happy to kind of send it to you or let you know. The history is critical in neurology, okay? And we begin the neurologic exam actually in the waiting room. So most neurologists, you will see, have waiting rooms, and then they have a long walkway to the examination room. And there's a reason for that, because what we like to do is watch the patient as we bring them in, walk. That's kind of the first thing we do. So the neurologic exam begins the moment you put your eyes on the patient, the moment they say something, the moment you see them get out of their chair and come into the examination room. So for me, neurology is visual. It's very visual. And many times I kind of play this game at the airport when I'm waiting for the plane to come in, and I have 1 hour to sit there. I watch people. I love watching people and trying to make diagnoses about their neurologic illnesses. For example, in sleep disturbance, I can usually diagnose somebody with sleep apnea, and we'll get into it, why and how and so forth. But so neurology is very observant, observational skills. When we begin in the history, you will see how I obtained my history from the patients. I spend most of my time on the history, 85% to 90%, asking questions, evaluating the patient. And I only spend about 5% or 10% on the physical exam. Why is that? The history gives the answer most of the time. Most of the time, unlike in other fields in medicine. By talking to the patient, and not only one time, but in subsequent visits, you get a differential diagnosis, which is so important. So in the history, what do we ask? We ask about the age, handedness, very important in neurology, occupation. Where do they live? In an apartment or in a house, a big house, small, old house? Marital status. I always ask about military, kind of tells us a little bit about trauma, military. One of the questions I always ask, and I notice that students rarely ask, is, how did you find me? How did you get here? Was the patient brought from a nursing home? Did the patient come from a family member who's also sick, etc.? So that's an important question. I think the family history is very important. We always ask about the family. And then, because I was trained in internal medicine, I like to know about the medical background. Many medical illnesses, you develop neurological complications. And there are many diseases which are only neurological, but the past medical history is very important. I like to ask about surgical history. Previous hospitalizations can give you an insight, history of trauma. I like to ask about their marital status, children, even menstrual. They may be post-menstruation, maybe difficulties from that, or they may have primary or secondary amenorrhea, etc. Work history. Also, always ask about whether there's a legal issue or a forensic issue. Some of the patients we see, especially in the United States, have attorneys, but you may not get that history for a while, second, third visit. I have been fooled, I use the word fooled, because the patient didn't tell me. Of course, I didn't ask. So you can always say to yourself, well, you didn't ask, which is true. Sometimes they have an attorney and they're maybe shy, maybe ashamed of telling me, etc. So it takes a while until the patient warms up to you. So in the history, fairly complicated. I go over the review of systems. Are you familiar with that? And I usually have 25 bullets, I call them, 25 bullets. I ask about the nature of the illness. If it's pain, for example, how many of you have seen a patient who has pain? Common, right? So we ask about detailed questions about the pain. Where is it? When did it start? Does it get better? Does it get worse? What makes it better? What makes it worse? Does it radiate? Is it always in one spot, et cetera, et cetera? We were interested in hypertension as neurologists, of course. We're interested in atherosclerotic vascular disease, of course. We're interested in cardiac, especially cardiac arrhythmia. We're interested in pulmonary disease. And I usually ask about gastrointestinal problems, and I ask about lung disease. I think it's very important for the student because you don't have to have all of the history on the first visit. Ask about the majority of the items, but you may not get to ask about everything. But you'll have another follow-up. I always try to bring the patient back and follow up more questions, etc. At this point, I want to tell you something I learned from one of my teachers who said to me, and he was a gynecologist, obstetrician gynecologist, very wonderful doctor. He said, always think about the ticket of admission syndrome. How many of you know what that means? It's called the ticket of admission. The patient may come to me and complain about headache, typically as a neurologist, but their real problem is something else. Maybe the husband is beating them. She, let's say, cannot tell me that on the first visit, but it's called the ticket of admission syndrome. So she comes with something that is common, headache. Doctor, I have a headache. You try to figure it out in the history, but you don't ask about the marital situation, etc. You do the physical exam, you do the laboratory study. But the real reason that they're there is because of some kind of head injury that the husband is committing and so forth. There may be some other issues where a patient comes in with something simple, arm pain, working them up for arm pain, arm pain. You discover that it's a totally different kind of issue. They may be worried about muscle disease because there's an uncle or aunt who had myotonic dystrophy. And they can't actually tell you that that's what worries them. So we call this, or I call it, ticket of admission. So have you heard that before? Very important as a neurologist that always have in the back of your mind, what is the real reason that the patient sees? And in the United States, especially around here in Washington, there's so many lawyers, you know, it's estimated maybe 200,000 lawyers just all hovering around here. So many people have some kind of legal issue, but they may not tell you on the first visit, or even the second, or even the third. So they come in with something, they fell and they hurt their ankle. Turns out that they were in a car accident a month ago, et cetera, et cetera, et cetera. So always ask about the real reason, the ticket. You don't ask the patient, well, what's the real reason you're here? You have it in your mind that there may be something else in terms of what they're complaining. I wanted to mention that. Always ask about children. And I should say that because I see children as well in pediatrics, we're always interested in pregnancy, problems, the gestation, how long was the pregnancy, delivery. And then I'm always interested in the milestones. We use the word milestones, children's milestones. How many of you are interested in pediatrics? Anybody? Okay. Well, we do see kids here. I love to see kids because I have 3 sons myself, but children are so natural. They don't have secondary gain. They don't have alternative reasons for being there, you know? They may be complicated, but usually you don't have to worry about the psychology or the psychiatry. Pure neurology. So you do a neurologic exam, you'll see the pure neurology. So I do like children. So then you go from the review systems, you go the story of the present illness. And so you focus on what the illness is. always remember that some of the illnesses are actually drug-induced. I was told yesterday, one of our patients that we're seeing on Zoom, which looked like she had kind of end-stage dementia, 88-year-old lady. And what we did is we modified the Seroquel, we modified one of the medications, and she's now bright. And the children called me out yesterday, in fact, saying, Dr. Bernad, we have our mother back. That was the word they used. We have the mother back. In other words, her mentation is now so remarkably improved. So always think about drugs, drug-induced. We're very interested in loss of interest in a patient, a loss of drive, loss of energy, and frequently it suggests some kind of mentation problem. And we're going to get into how to evaluate that. Think about the headache. Think about the 4Ds. Who knows the 4Ds in a patient with altered mental status? The 4Ds, kind of simple to remember. Mnemonic. Anybody? Depression. Very good. Dementia too. What else? Delirium. Excellent. What's the fourth? Drugs. You passed. You're ready to go. So you've had training in neurology?
Yes, I've had one clinical rotation.
You could tell right away, but those are the 4Ds. Good, very good. Always think about those four. So when we're asking the history, we're interested in disorders of memory, thinking, always headache, very important. Then we come to a separate area in the history, which is loss of consciousness. So there's a series of questions around loss of consciousness. Was there an aura? Was there movement? Was it like a seizure, or was it syncope? Were there visual changes? We ask about hearing, change in speech, difficulty swallowing. And then a separate category in neurology is the movement disorder. So we ask about tremor, syncope, spinal pain. Pain is a big issue, of course. And just a kind of another point that I like, and I got in trouble on the first day of my neurology training. Dr. Larrick informed the boss, Dr. Adams, why they selected me at Harvard. This is at Harvard. And I never lived it down. I didn't ask the family history of the patient who turned out to have dementia. Dr. Larrick chewed me out. Never forget it. This was talking about 40 years ago. Very important to have a family member or somebody else come with the family in a dementia case. I've seen patients here who have memory loss and somehow somebody drops them off, like a son or a daughter, and they come in and I'm talking to them and they seem to be reasonable. The problem is memory loss. They have a memory issue. So always have a friend or a family member or a spouse come. Okay, so I just want to say that we spend a long time on the history, and the second part of the neurologic exam will be the physical exam, but the two are intertwined. I usually do part of my physical exam getting the history, and I do some of my history when I do the physical exam, and you're allowed to do that. You don't have to separate the two. So what I'm going to be doing in this month is kind of basic neurologic exam, personal approach, logical, systematic, practical, kind of a screening neurologic evaluation. In neurology, it's very important that we spend some understanding time in neuroanatomy. How many of you have had formal neuroanatomy training? Well, you did it. That's kind of critical because neurology has a lot to do with anatomy. So the first thing we do in our minds as neurologists is to think about the neuroanatomic localization of where this problem is: upper motor neuron, lower motor neuron, cortical, spinal cord, peripheral nerve, etc., autonomic neuropathy. Then when we've done the neuroanatomic localization, we can think about neurochemistry, Parkinson's disease. We can talk about neurophysiology, and then go down into a region called the differential diagnosis. And only after the differential diagnosis, we come up with certain treatments or plans or prognosis. So a neurologist works in a systematic way before you arrive at a potential diagnosis. It's always good to have a differential diagnosis. So diagnostic studies are done after you've arrived at the differential diagnosis, and you bring the patient back for a second go. So one thing I'm going to leave with, I'm going to blow my nose for a minute. Let me just blow my nose here. Talking about, this is the weakness that I've seen in young doctors. Differential diagnosis. It's hard for them to come up with differential diagnosis. So, how many of you have heard of Occam's razor? Or, okay, go ahead.
Most likely diagnosis, or the most likely solution to a problem, is the most practical one, the one that reaches the problem directly and
Exactly.
around.
So this is she's so good. Dr. Stein, we have a wonderful person here. Obviously you've thought about this. So I like the notion of Occam. Occam was a Franciscan friar, and he came up with this notion of the solution to a problem is usually the simplest and the most direct, rather than looking at other explanations and including other possibilities, etc. Now, it works, but it doesn't work all the time. So you have to be careful with it. But generally, for example, somebody comes in with a headache, okay, 30-year-old female with headache. It's not going to be a brain tumor. It's more likely going to be migraine. Not 100% of the time, but most of the time. So I'd like to leave you with that notion. Kind of, it's a philosophic assessment, philosophic approach to neurologic diseases. So today I wanted to cover the history, and we will talk about it later. The physical exam I'm going to cover in the next talk, and we're going to systematically go through all aspects of the neurologic examination. Okay, so you could prepare by maybe reading a little bit on the physical exam. Was this helpful? A little bit, kind of a little introduction. This is just my philosophy. It's actually philosophical. It's what has helped me over the years doing frequent neurologic exams. Right now we have about 76,000 patients actually numbered, but I saw many patients before that, but they were not on our computers. They were all over the world. Wait, tell me again, where are you from?
Atlanta. I studied in UAE though. I didn't remember.
You're from Beirut. Who's from Beirut? Well, you see, yeah, that's what. Excellent teaching, very Americanized. So she's really very good. And of course, Svetlana is from Russia, the Russian. Did you have good neurological?
Yes.
Yes, very good. Yeah, of course. so many tremendous, very famous Russian neurologists over the years. And then you're from Colombia, also, of course, excellent South American colleagues and Spanish. Any questions about what I said? Any questions, explanations? It's just my approach. There are many other approaches. This is the one that I like, that I've learned from so many people who have influenced me. So, you have any questions? Anything that you want to ask?
I have a question.
Sure.
Doctor, as we mentioned, that a 30-year-old female coming with headache, the most likely cause is migraine. And if you determine through history and physical that everything's fine, and you really think it's a migraine, do you still need to do imaging just to make sure to rule out that there's no tumor there?
I can go both ways. Again, in terms of the situation, let's say the person has no insurance, let's say the person has no money. I take that into consideration. For individuals, ordinarily, in an ordinary case, I would like to do, let's say, a CAT scan, but it is controversial what you do. Even in the emergency room, somebody comes with a severe headache. Again, it depends. Have they had a previous history? Family history is positive. Mother had migraine. Sister has migraine. So, when you hear hoofs, have you heard of that? It's an American. When you hear hoofs, don't think of zebras. More like a horse, something. But again, it depends on so many factors. So I can't say that automatically I get imaging. I tend to want to get imaging and even an electroencephalogram, etc. I always also think about not hurting the patient. So I take that into consideration. Radiation is a consideration. The cost is a consideration. Pain, for example, injection. I will get a CAT scan without contrast so that I don't add contrast. MRI, I don't add gadolinium. Go ahead.
Would it be safe to start treating them as a migraine and see if their symptoms improved on the migraine treatment?
Yes, well, I usually do that. So when I see the patient the first time, it sounds like migraine, it looks like migraine, normal examination. I would consider treating the person, even on the first visit, to alleviate the pain while I'm continuing to work up the patient. There are many. It's a very good question. The answer is somewhat difficult because you want to take into consideration the entirety of the person. Okay, that raises another issue. I don't treat disease. I like to treat the human being. So that's also my personal approach. I'd rather treat a whole person. And that's one of the reasons we ask so many questions in the history. And many of my colleagues who disagree with me, but I like to treat the entire person. So rather than the disease, in a sense, the disease comes with the patient rather than the patient coming with a disease. I don't find it interesting to just treat a disease. I find it interesting to treat a human being. Remember that many illnesses may appear different in different people, depending on their own background and life history and so forth. I hope this was helpful. We can go and see patients. Dr. Stein?
Yes, sir.
Okay, so that ends the history part.